Hello, everyone. Welcome to our second Pennsylvania MGMA Power Lunch. I want to give a few more people, a couple latecomers, I think, a second to get into the room. Um, my name is Erin, and I am pleased to welcome you to our program today. I am want to say thank you and welcome to our moderator today, David Regan. Regan, I did it. He said I would mess it up and 50% of the population would do it. I did it anyway. David Regan, who is a member of our board. David is an FACMPE, and he is the Senior Director of Network Development for WellSpan Medical Group, and he's working from his home in Lancaster right now. David is going to be discussing with us, or just discussing with the group, some of the government regulations and changes over the past year and up to the minute. I hope everybody's ready to chat with him. I'd encourage you to turn on your cameras and open up your mics as you're able and join the conversation. So, David, do you want to take it away?
Sure. Thanks for the introduction, Erin. Be with everyone, and good afternoon. I'd like to acknowledge a few people who helped put this together. First is Erin. She's our behind the scenes person and makes the technology work, which is good, because if you relied on me, we'd be doing a conference call, probably not Zoom. So also like to acknowledge Paul Brewer, who I see is on the call, and Autumn Hassinger, who are on the Pennsylvania MGMA's legislative committee for the board. So appreciate their help and support. Also like to put in a shameless plug for a meeting that's being sponsored by the Pennsylvania MGMA in April. It's Innovation in Medical Practice Management. It's a 2-day workshop. It's done in sort of tight bundles of 11 to 2 each day. That would be April 13, April 14. And I invite you to attend if you can. And the prices for members is very affordable. It's $65 a person, even for non-members at $99 a person. It's a good value. And so even if you can't hit all 6 of the meetings, it definitely is something I think would be worth your time. And, we have topics regarding employee engagement, burnout, dealing with value-based programs, the future of healthcare, which sounds interesting to me because I've learned that my crystal ball is completely broken. I have no idea what's going to happen tomorrow, as well as the less than fun stuff, but important hiring and firing, how you do that the right way. And I think I've maybe heard that talk before. It was very helpful. So today's topic really is to talk about government relations and government programs and how they impact your practice. Everyone on the call is considered an expert because we all interact with that in a different fashion. So you may be dealing with it, in the trenches, so to speak, and the primary contact person for your group in those, or you may be like me where somebody else is handling it, but I have general awareness of that. So, that'll be the topic. And it doesn't mean we can't veer from sort of that starting agenda item. So I encourage everyone to share good experiences, expertise if you think you have it, or even less than desirable outcomes. And what are you struggling with? Because all of that is useful feedback for those of us who are board members in Pennsylvania MGMA. Is one of our jobs is try to represent what's going on in the practice world out there. And then I debated whether to share this or not, but I think I'm going to, because it's a somewhat negative start of a program, and you're probably not supposed to do that. But I get a lot of newsletters, and I actually read them. And I was surprised today to read the headline is California Medical Group to close and lay off 151 people. And I'm thinking, how would you get to the point where you would close your practice? And it doesn't tell you a lot, but this was a substantial group. I think 26 physicians, 7 nurse practitioners, and they just decided to go out of business. And they're based in Northern California. So I think sometimes because we've done a good job adapting to the crazy world in the past, that maybe people overestimate what they're able to do. So I think it's appropriate we're talking about the support programs because they have helped many, if not all of us, carry through this COVID pandemic and deal with the financial consequences of that. So let me start with sort of setting the stage regarding our topic, and then I'll call on you if I feel that we are having a lull, but I'd like to hear what people are experiencing. So be interesting to hear from each of you if possible. What programs have you applied for? Which ones have you received support from? So there's a PPP program, there are employee retention credits, there's the provider relief funds, which I'm a new student of, learning more about those, as well as the Medicare Accelerated and Advanced Payment programs. And we're interested in just one, who's using those and have found them helpful, and maybe if you haven't applied for those programs, what was your situation and why that occurred? So let me stop with that sort of topic and proposal and open the floor to whoever would like to share first. It has to be a brave person.
Well, I'll start. We are a specialty practice here in the Pittsburgh area. We have 8 offices, the one being an administrative office. And we applied, we are on our second PPP loan. And we had received one stimulus from HHS. So that is what we have received and has been able to keep our doors and lights on and open.
Hi, this is Paul. And our situation is very similar. Also a specialty practice, and we applied for and had received the first and the second PPP loan. We also received the stimulus payment back in April. And I think like most practices, we've registered, but have not yet begun the application for that provider relief fund stimulus payment. As I understand, that's still not open. Mm-hmm. We chose not to participate in the Medicare Accelerated Payment mm-hmm. program, primarily because I thought it was going to be really complex in terms of trying to figure out how to reallocate that money per provider the following year. And we felt that at the time, based on the PPP loan that we received, that we probably didn't need those funds and that it was going to probably result in more challenges than benefit.
And I agree with Paul.
Paul and or Heidi, have you, where are you in the process of having your PPP loans forgiven and submitting all that paperwork? I know from experience, it was a bit of a challenge early on because the banks were handling it, not always prepared for it, and sometimes weren't getting the consistent guidance that we wish they would have gotten.
I've received everything back from the accountant. I have to just now pull the canceled checks and I'm ready to go into the portal and submit. So I should have it all done probably by April 15th. I know you have 10 months from the completion date, so I'm only 2 months in, but I would like to have it done sooner than later.
Similar situation here. We have all of the data ready to go.
Mm-hmm.
We have everything in a format that we can easily submit it. The bank we're working with has told us that at this point they're not ready to receive the forgiveness application. So kind of like Heidi, we're just really waiting to be given that green light and go ahead and enter the data for the first one.
Okay, very good.
David, I'm in a situation of blissful ignorance, which might be similar to WellSpan in that as a hospital-owned entity, the hospital finance department has taken over all the activity, which the good news, they do all the work. The bad news is we have less direct control or knowledge at the practice level. But I know we've been well supported by government entities through the COVID process, but we also are the designated county entity to provide all the vaccinations to the public. So we've incurred significant expense in terms of personnel use for non-practice activity to vaccinate. Right now, we're at about 30,000 vaccinations. So we've incurred a great deal of costs, have been supported, but in honest answer to your question, most has been done at the hospital level, so we're not really directly involved.
Okay, thanks, Jim. Anybody else? I can't necessarily see everyone who's on the call, so I'll allow some periods of silence for folks to jump in. Okay. I guess, so people have, I guess some people, it sounds like, have gotten on the Provider Relief Fund portal, have tried it, found that I know I've read also, I don't personally do it, that there's limited options on what you can do on that portal. Has anyone had a sort of different experience with that, or is that pretty much where it's at today? I think, one of the things that I did read in about that program was there's a lot more data reporting requirements. As you look at accessing those funds or contemplating accessing those funds, are those reporting requirements kind of a barrier to perhaps your group participating? So, they want you to, they want demographics reported, they want you to track expenses, even track your interest earned, like, which I chuckled at that because, we're all earning like at least, a fraction of a % on our savings accounts. Like, why the government thought that was something to worry about. It was interesting, but staffing, patient care metrics. So the reporting burden feels like it's getting a little heavier. Appreciate that, if the government gives you money, you probably, have some obligation to sort of show that it was used as intended and appropriate. But I'm curious to see where people are in taking a look at that process and where that might factor into your decision-making process. Or is that maybe too early to tell? I see Heidi, so I know she'll speak up.
Oh, well, with the second PPP loan, they gave us a little bit more we could use. Now they're allowing us to use money towards PPP or PPE, where the first loan we wasn't allowed. So they gave us a little bit more flexibility with this cost of expenses, so forth. Applying for the HHS stimulus, those applications were bare. We did not qualify for round 2 or 3. But you still apply just in case.
Sure. Do they say why you don't qualify, or is it self-evident as you fill out the application?
It's all about revenue and things like that, your losses. So we did not receive anything for round 2. Round 3, we received notification that we will receive money for what they call that, the overflow. And that's at the end of round 3. I've still not yet received notification from Opt and Pay that it's should be coming. And that's about 2% of your patient revenue.
Okay. All right. Well, thanks. In the process, have folks found where are there websites or resources that are useful that you might share on how to do this, or the strategies behind how you present your case, if you will, to apply for these funds? I know I have like a dozen COVID emails a day coming at me. I don't always read them sometimes because it's all the clinical stuff that unless I'm getting a shot in my arm, I'm not too worried about. But I'm curious to see if people found a web page or a source that was useful that they might share with others.
Well, I think one of the challenges we've had is ensuring that the information from the State Department of Health and the CDC are consistent with one another, and often they are not. When President Biden speaks about the teachers should be vaccinated, and that's not part of 1A in Pennsylvania, it gets very confusing. So I know this isn't on the financial end, but on the practical end, there's conflicting government information, which makes it very difficult to manage patient expectations. But both sides, the CDC and the Department of Health, are really very good. They just aren't consistent.
Yeah, I know in the York WellSpan system, we've been challenged with that too, because even to the point where teachers are sent to separate centers away from, so even if in some counties we are the primary vaccination center, in other areas we are participants. So, teachers were sent to different locations because that's where they were shipping the vaccine that was designated for teachers, even though they could have the other vaccines. So I think we experienced that too, along with knowing the volumes and, the dependability of the supply chain has been, I think, a challenge in planning. All right. So I'm hearing not a lot of hot and current interest in some of these programs. Certainly, my experience and as I communicated with practices I interact with outside of my employee group definitely were helpful in carrying groups forward, allowing them to keep staff and keep the doors open, or else mitigated, reduced the negative impact of the volume challenges. I would be interested in hearing, and I think it would be interesting for the group to hear, pretend 2019 was a normal year, and we know 2020 was an abnormal year, but where do people see their volumes at relative to that base year of 2019? So it doesn't have to be any precision here, just are you about the same as 2019, or you're below 5% below, or maybe, I'd be interested in hearing where people, whether you measure in patients or dollars, see their current volumes, because I think everyone is trying to figure out what is the new normal. It probably varies by specialty. So if we could sort of go around the room and ask that people share that if they have some sense of that.
Well, as a multi-specialty group, it does vary by specialty. We track office utilization by week. And right now, over the past week, we're at 98% of pre-COVID levels in the office across the organization. Some are significantly above, and that's just the nature of the business. In urology, as an example, we're sort of the sole provider in a large region. So they're at about 127%, as I recall. And then the couple of stragglers are just sort of in some unique areas that are still challenged by face-to-face patient activity. Physical therapy is, I think, at about 80% of pre-COVID levels, because obviously not going to do a lot of tele-physical therapy.
Thanks, Jim.
And surgery volume right now is back to normal. But that's literally week to week, and it's, you never know what's going to crop up. And in Centre County right now, we're having a bit of a COVID surge, although it's mostly related to Penn State students. But we had to open our inpatient COVID unit again this week.
Is that spring break activity, go down to Florida, get COVID, bring it back to Pennsylvania?
Yep, we assume. Really happy about that.
Yeah, some guess. All right. Heidi, pick on you because I can see you on my screen. How's your practice doing?
We're probably at about 80%. We're physical medicine and rehab, or physiatrists. So I've got 5 physicians, 3 of which strictly do EMGs 100%. So no telemedicine. You can't stick a patient through the screen with a needle. During when COVID was hot and heavy, we'd had one provider would do some telemedicine with her amputee patients. We've had to stretch our appointments from 45 to 60. Some went a little longer to assure proper cleaning. So we're about 80%, and I think that's probably our new normal now. So we're now trying to think outside the box for a little bit different sources of revenue.
Okay. Makes sense. Paul?
We are back up to about 90% of where we were first quarter 2019. And where we're still falling below that is really more related to telehealth. We've, for the most part, have eliminated the telehealth, but there are still some doctors that are offering it more as a convenience. So when I factor in the telehealth, we're even closer to say 95% of where we were first quarter 2019. So we have more or less rebounded from our COVID year.
Okay. Sounds good. Liz, if you're on and paying attention, could you share what's going on in your practice? I know sometimes people have to run out of the room.
Mhm.
Anybody else who's on the call would be willing to share where they are?
Amy Jo, I can talk about the Women's Institute. I work at Allegheny Health Network in Pittsburgh, Pennsylvania. But our volume right now is about 60% of what it was pre-COVID. And I think one of the main reasons is our bread and butter is really those annual women's exams. And the insurance companies only pay for those once a year, which is once every 365 days. So last year, this time, the Pennsylvania Department of Health had us discontinue seeing those patients until probably, I think, July, August, or September. So we rescheduled a lot of patients from February, March, and April later in the summer. So now my doctors are sitting there with maybe 50% scheduled utilization. But I have a feeling in August and September, they're going to be jammed up. So we'll be at 100% utilization. So it's kind of changed the way our cycle is now in the practice. And that's a forever change because of how the insurance pays work. We've noticed our OB volume has gone down. We thought maybe we would have a surge with COVID, but we actually did not.
Okay. So, and I did, you were a little scratchy there. Did I hear correctly? You're a OBGYN practice?
Correct.
Okay. Yeah, that's interesting because we definitely saw in some areas that, well women visits deferred because people just didn't want to go into settings where there might be COVID. And we're in the process of rebounding as well in most of our OBGYN practices. Anybody else who would like to weigh in? Okay. I'm going to ask a related question, and I know Paul touched upon it, but we, in the WellSpan system, we, had effectively an overnight dramatic increase in our televisits, which were helpful for continuity of care and health maintenance. It was helpful from a business standpoint because we were at least generating some revenue instead of none. And then we struggled to decide what's the right number going forward because we think physicians are used to and comfortable with seeing patients in a certain manner. If you rely more on telemedicine visits, there's still the need for inpatient or in-person care is important because there are some procedures that only can be done in person. And quite frankly, meeting Mr. Smith on Zoom is okay for a lot of things, but not for everything. Sometimes you really do need to listen to the heart and lungs and examine things in patients in person. Curious to see if people have any deliberate strategies or goals regarding their telemedicine, piece of their practice. Do they have a goal to say 10% of our visits will be done through telemedicine, or and or maybe more or maybe less, or are doctors using it to, see patients, from home on Wednesday afternoons instead of coming to the office, perhaps. So I'd be interested in seeing how people are using this new version of access, which is, COVID allowed, one of the positive things that it kind of allowed us to get over the insurance barrier that had been there for so many years. So how's that going today? So if you would be nice enough to share, I know I'm interested and the rest of the group is interested.
Well, as long as there's economic support from payers, we're going to be very supportive. But interestingly, some of the things we encountered are, first of all, patients in this central rural part of the state are very much committed to coming to the office. So we've had two difficulties in fully implementing telehealth, one of which is patient perspective, and the second is Wi-Fi access. You'd assume in State College, Pennsylvania, with Penn State University here, everybody would have Wi-Fi, but in fact, of my 8 cardiologists, 5 of them live in an area without Wi-Fi at home. So you don't have to get too far out of State College before you're in the woods. So it was a real access issue with the public and in some cases with our providers that we hadn't fully anticipated until COVID made us wade deeply into the telehealth environment. So frankly, we have a big building project underway, and we had to step back and reevaluate the project to ensure we didn't replicate, the historic exam room arrangement. But quite frankly, at the end of it, we're probably thinking no more than 20% is the future because, first of all, we have a telehealth access issue, but secondly, there's not great public acceptance. So we found that a really nice convenience in some instances, and a handful of patients really like it, but generally speaking, unless it's that truly acute visit that's easier to get on the phone or computer as opposed to even go to urgent care, for the most part, people have not been terribly supportive in this part of the state.
Makes sense. I appreciate that rural access issue. We just hired a radiologist who wants to have a home reading station. And again, we're debating whether to, pay Comcast or whoever the local vendor is to run cable just so we can get some high-speed access so this physician can do her work. So those issues are pretty real. And I'm talking to you from Lancaster County, where my home. And if you looked outside my house, you'd say, "Oh, Dave, it looks like you live in a normal, regular subdivision." But even on the edges of some of the suburban areas, Wi-Fi, cell signals, and high-speed internet is still not a guaranteed thing. Who else has been sort of working on their strategy or approach or about how telemedicine fits into their practice's future?
This is Paul. I think that we realize that it's a opportunity that will continue to exist, hopefully for a while. So as physicians are interested in incorporating it into their day, sometimes more for the convenience of patients, we will continue to provide it. And it may well be that it's only 2% or less of patients maybe for each doctor on a given day, but we do have some physicians that have carved out specific times. You use the example of, an afternoon. Well, we have one physician that uses on Monday morning to just dedicate that to telehealth appointments. And I think we will continue to do that for the foreseeable future.
Okay, thanks, Paul. I'll share, again, I shared WellSpan, something we looked at. Initially, everyone thought, well, let's keep our telehealth numbers up as high as they are in the peak of the pandemic. And then we can close, 30% of our offices. That turned out that really wasn't a realistic strategy. There's, again, a good reason for in-person visits, in most cases. different kinds of, ability to access versus, a patient trying to do it on a phone versus a computer at home, very different experience. So something still in progress for us. I don't believe we set goals, but I think we just look at it as an opportunity. It can be another doorway into the practice, if you will. And again, there will be a group of people who are interested in that and will take advantage of that. We're also working on, we sort of ran an experimental practice during all of this. It actually was up and running prior to COVID, where we attempted to have an online primary care practice. And then it was essentially where most all your care was done online or through electronic tools of emails and messaging through our electronic medical record system. And that definitely was something that there was a population out there who wanted that. Not, I won't say the vast majority, but that practice was able to, kind of keep going on. And then when COVID came, it really, really grew. So we're looking at how do we make that slick enough, to use a very highly technical management word, so that people really would be attracted to that, as well as building in the backup systems for, when should somebody come in, when do you no longer trust the blood pressure cuff that a patient had, bought at the drugstore, and in fact, want to take pressures or take temperatures in ways that you're more, or just examine the patient. So very much a work in progress. We're not declaring success, but we are experimenting with it, because again, I think in the, as the future evolves, there'll be a group of people where that's a good tool for a certain part of our patient population.
One area that's really been positive, David, is we are pleasantly in an area with a number of prisons. And so we have reached out to the Department of Corrections to offer them as a multi-specialty group, kind of a soup to nuts program of telehealth access for prisoners. And, we're negotiating a reimbursement rate and don't really expect it to make a lot of money necessarily, given the nature of reimbursement from the state and prison system. But what it would do is keep, 2 armed guards and a guy in shackles out of our offices. Not that that's, a horrible thing, but it's awkward for patients at times. And frankly, it's really very disruptive and costly for the state. So we're phrasing this in a way of, here's how we can help you. And they've been surprisingly receptive to trying to consider how they would arrange the technology to support that program. And another quick thought is, I have 2 part-time younger female board certified mammographers, and not just radiology, but actually board certified mammography as well, a second credential. And the ability to set them up at home, I'm not sure if this will help your thoughts at all, but setting them up at home has them working to about a 1.6 FTE for a 1.2 provider FTE. They're extremely productive at home, obviously doing screenings, not diagnostics, but it's been a real asset, which saved us from hiring a 3rd mammographer.
It is interesting. As I live in a larger system, and we're looking at how we do radiology services and share resources even across different markets or different hospitals. These electronic tools have a lot of potential. So we have only 10 minutes left in this discussion. I think we've sort of gone down a number of paths that were interesting and helpful in terms of dealing with COVID, dealing with the government programs, as well as our own just, what resources do we have inside our practice and our health system to respond. Interested if there are any questions or issues outside of this topic that, might be related to government programs that folks would like to discuss. express concern or frustration about, kind of open the floor up to the group and see if there's something else that is of interest to you.
I thought I would just bring up MIPS since we're all either have or are about to submit or not submit for MIPS this year, and just kind of curious what others have decided related to the MIPS program. I know despite COVID last year, we continued to move forward with meeting all of the quality measures and decided that we thought we still had a decent score. So we did go ahead and submit, but I know that in the almost 11th hour, there was a lot of information coming down about how you could basically take a neutral year if I felt that was to your advantage. And I'm just curious what others have decided related to MIPS.
We perform pretty well, so we're filing for 21 right now.
Yeah.
I'd share our WellSpan experience, but I actually don't know what it is that gets handled. I'm like Jim, who sometimes suffer from delightful ignorance of a certain issue because we have a system that takes care of that. And we do have sort of a managed care plan and internal care management system for employees that ends up helping us handle that. So one of my, should go back and I probably should know the answer to that question. Heidi, what are you thinking?
Well, we applied for the extreme uncontrollable exceptions and we received it across the board. So I did not have to submit anything for 2020. MIPS is very difficult for the type of specialty we do. Since we're physical medicine and rehab, there's very few measures. And I get pushback from my physicians to even do measures. But we did receive that across the board. Had we not done, and we did them just in case, because it's not a given that we would have been awarded that exception. Had we not been awarded, we would have not even made the 45 points. I did have 2 offices closed for the month of April in the first week and a half of May because they were in hospital settings in the professional office side of a hospital. And the patients just did not feel comfortable. It was nothing that we did. We didn't close it personally, but the patients did not want to walk through a hospital during that time.
Mm-hmm.
So therefore, we just didn't have the volume. When they came back, the physicians wasn't having us do blood pressures. So our measures just plummeted. So we're on par right now. 60 points for our practice is a lot, but I've been working really hard. We use Mingle Analytics, who is highly recommended from the Pennsylvania Medical Society. We do claim submissions because our physicians don't work through the EMR system. So we do codes through the claims, capture them that way. And Mingle works with me hand in hand. And right now we're on par to be able to at least hit our 60 points. And, I do a happy dance if I can at least break even.
Thank you. Thanks for sharing, Heidi.
You're welcome.
Yeah, I do. I live in a very large multi-specialty practice group, and I appreciate some of the challenges.
Oh, it's a challenge.
Yeah, I mean, it's just tough because some of these programs get written as if everybody is a primary care doc, and that's just not the case. So
Yeah.
all right, Amy Jo, I'm going to see if I could get you to respond. You shared with us before. What's going on with your practice in MIPS?
So I don't know if you can actually hear me okay. Is that better?
A tad scratchy, but we're hearing you.
Okay. So for MIPS, being a part of OBGYN, our practice uses a system called Epic, which I'm sure a lot of you know about. what's going on with MIPS. I know that, you know, some of the, we have some things to work on, and it has to do with us not being able to do mammograms and see some of the patients during the COVID time. So there are some tools there, but I know that that falls more on the primary care doctors, not us.
Okay, thank you.
Sure.
Anyone else who would like to jump in? Seems what, a slightly shy group today. Okay. I'm sure another thing I read yesterday morning. I don't know where people are and worrying about things. Having been in practice management more than just a couple of years, I think almost my entire career, we were always under the threat of some form of sequestration or payment reduction threat. And it actually became a little bit of a kabuki theater event where every year, oh, we're facing this percent, and the percents went up. You know, there was 10% or, you know, it was high numbers. And then every year, Congress would kind of ride in on a white horse and make that go away for 1, maybe 2 years. And sequestration continues to be a tool that the legislative body of our federal government wants to use when putting their budgets together, and then they seem to not want to actually pull the trigger on those. I know I won't go into the politics, but I've had enough government relations experts just say it's politically dangerous for them because Medicare patients typically are retired, near retirement, and have time on their hands, and will create a lot of political heat for that. So the most recent feedback I've heard from 2 different professional organizations about that is that the 2% Medicare sequester that was delayed only until the end of 2021, so December 31st, 2021, would be that can would be kicked down the lane again, and they know, everyone seems confident about that. They speak to it like it's a done deal. So folks who follow legislative matters closely and folks who have connections with that are pretty comfortable that that will not be an extra financial headache for practices that serve Medicare patients. There's also, I think, was more of an unintended consequence and related to a formula that was written into a COVID bill, the one called the American Rescue Plan, that would have actually or could lead in theory to a 4% sequester that would not go into effect until January of 2022. And people, again, from the professional organizations I've heard it from, are speaking with a fairly high degree of confidence that that will go away too. And so every year we, are dealing with the cost of Medicare and healthcare in this country is problematic, but using payment reductions as one of the tools to confront that doesn't seem that that's going to proceed soon. I think it's more about trying to push us into I'll say managed care type arrangements where there's some risk, some reward, some accountability in our performance. So I just share that because, again, when I get the same message from 2 independent organizations that are well known and highly regarded, that seems to be something that will not be a worry for us to deal with in the future, at least as best as anyone can say in these turbulent times. So I shared with bad news about a practice closing and just scratching my head on how could that happen? Because it seems to me you could, do something about it with, restructuring the group or, changing your overhead or something instead of just giving up. So I found that interesting. And maybe it's a bit of a red herring in terms of what's going out there. I think it's not a red herring in terms of we're all dealing with economic pressures that are increasing, and COVID made them both a bit worse, if you will, and definitely a bit more complicated. So I appreciate everyone sharing their experience with those programs and what people are doing and how they're responding. It helps me, to kind of learn and appreciate what's happening out in the real world. Because sometimes when you're in a big health system, you don't always feel like you're in the real world. So as a board member, I'm grateful for that reflection and background. We're out of time, so I'm going to wrap up the phone call. Unless there are any last minute points or questions or things that folks would like to share with us.
I just want to thank David and thank you all for joining us today. I hope you'll join us again. I hope you'll join us in April for our 2-day workshop, and then again in April for our more informal discussion for our power lunch. So thanks, David, that you were a trooper, and thank you all for your contributions to the conversation. I hope you all have a great afternoon.
Thank you, David. Thank you, Aaron.
Thanks, everybody.
Thank you.
Bye.
Have a
Great
great
to meet you or see ya. Take care.
Bye-bye.
Bye-bye.
David.
Bye-bye.
Thank you.